Assalamu alaikum wa rahmatullahi wa barakatuh. It's my pleasure to be a chair of this sessions of the International Conference, the annual virtual congress for the diabetes and endocrinology. Today is the first presenter here is Dr. Bashar Effendi. Dr. Bashar Effendi is the consultant endocrinology and head of Division, Tuam Hospital, clinical professor, Faculty of Medicine, Health Services in United Arab Emirates University. He graduated from Alibu University, Syria, and then he completed internal medicine internship and residency at the Lutheran Medical Center Research Institute, Brooklyn, New York. And he completed the fellowship in endocrinology and diabetes, hypertension, and metabolism at the State University of New York. He been appointed as a consultant endocrinologist since 2001. Dr. Bashar has been a member of multiple committees. I can just mention some of them. That is the member of the MENA Hyperglycemia and Pregnancy Guidelines Committee 2021 and the Diabetes Guidelines Committee United Arab Emirates 2012 and 20. Member of the DAR, which is Diabetes and Ramadan Committee Guidelines in 21 and 20. He is a co-founder of the Emirates Endocrine Club and Al Ain Endocrine Club, past chief endocrine division of the at the Lutheran Medical Center Research Institute, Brooklyn, New York. He has multiple, more than 60 publications in the local and international diabetes endocrine journals. He is a member of many of local and international diabetes and endocrine societies. Professor Bashar Effendi is going to talk today about challenging hypoglycemia cases. Please, Dr. Bashar.
Assalamu alaikum. Thank you, Mrs. Chairwoman. Good evening to everyone. My great pleasure to present in this meeting. In my talk, I will review the evaluation and management of hypoglycemia in non-diabetic adult patients. I have no conflict of interest in this presentation. I will discuss definition, classification, causes, evaluation, and management of hypoglycemia. And I have three clinical scenarios if time allows, because we lost some time, I could see that. So this is the most common presentation, a young lady with 3-year history of recurrent episodes of hypoglycemia or symptoms actually of sweating and palpitations for 3 years. And usually her symptoms are usually relieved when she eats or drinks juice. She was diagnosed last year as anxiety. Her BMI is 29. She has unremarkable physical examination, normal CBC, and normal thyroid function test. And the question now, what do you think is the most appropriate next step in the evaluation of this patient? Would you check her fasting blood glucose, insulin, and C-peptide? Would you admit her for a prolonged fasting test? Would you do a patient mixed meal test as an outpatient? Would you do the glucagon stimulation test? Or do you have any other preference that you would like to do? Just 1 second to think about it. And actually, the correct answer here is none of the above. Now, we get so many referrals like this patient, and according to literature, only 5 to 10% of these patients have true hypoglycemia. So before proceeding for evaluation of hypoglycemia, you actually must have to confirm hypoglycemia. To confirm hypoglycemia, patients should have the Whipple triad. They should have symptoms. They should have low blood glucose, confirmed one. And thirdly, they should their symptoms should be relieved after raising their blood levels. According to many international institutions, including the ADA, the ESD, and many other institutions, level of hypoglycemia are classified into level 1 when the blood glucose is between 54 and 70 milligram per deciliter, and level 2 when the blood glucose is less than 54 milligram per deciliter, and severe hypoglycemia whenever the patient has any altered mental status or they require assistance. Very important to know how individuals do respond to hypoglycemia. For example, when blood glucose is less than 80, the insulin level will start decreasing. And whenever the blood glucose is less than 60, then you have the glucose, the growth hormone and the cortisol actually will increase. And whenever the blood glucose is less than 55, then patients start getting symptoms. And at that time, insulin is completely suppressed. Also very important to know that lower blood glucose might happen with no sign and symptoms in many people, and as such, these people would not satisfy the Whipple triad definition. Now, symptoms of hypoglycemia are divided into two types, the warning symptoms, and these are actually related to sympathetic activation that include tremor, palpitation, sweating, anxiety, and hunger. And the real signs of hypoglycemia, and these are called the neuroglycopenic symptoms, and they are related to glucose deprivation in the brain. And these include confusion, difficulty speaking, dizziness, seizure, loss of consciousness, and coma. Please remember that recurrent hypoglycemia might impair hormonal counter-regulation. So patients will have less secretion of epinephrine and glucagon. Consequently, they might have more hypoglycemia and more dangerous hypoglycemia because of the hypoglycemic unawareness. We have a very long list of causes of hypoglycemia, including medications, malnutrition, sepsis, renal and liver and endocrine disorders, and post-bariatric surgery. Very important to remember here that pregnant women might also have lower blood glucose, especially those with lower age or lower BMI. They might have a blood glucose of less than 40 with no symptoms, of course. Again, we have a very long list of medications that might cause hypoglycemia, including most diabetes medications, heparin, aspirin, many hypertension medications, and antibiotics. Please review any medical reference for that. Very important to know these agents that might cause hypoglycemia. So, when evaluating hypoglycemia, full history and physical examination are essential. History is very important, and that includes types of symptoms, timing of episodes, and relation to food intake. You also must review social and past medical history for that patient, and medications and over-the-counter supplements, very important. Only after confirming hypoglycemia and understanding the history for that patient, you could go for lab evaluation. Labs include CBC, kidney and liver function test, cortisol and thyroid function test. And at the time of hypoglycemia, we should check the panel of blood glucose, insulin, C-peptide, and proinsulin, and ketones bodies, and insulin antibodies. And we must check patients for the presence of oral hypoglycemic agents. Now, diagnostic workup include prolonged supervised fasting, which is the gold standard in patients with fasting hypoglycemia. You must admit these patients to the hospital. Usually, fasting should start after the evening meal, and you should hold all non-essential medications. Labs should be done every 6 hours. We should check the blood glucose, the insulin, C-peptide, and proinsulin. And when the blood glucose is less than 60, then we have to monitor these patients closely and check their labs every 1 hour. Please note, and this is really very important, that water and caffeine-free drinks are permitted during the test. And also, we should allow patients to keep active during the test. So we don't ask them for rest during the test. Now, when the blood glucose is less than 50, again, we check the whole panel with the ketones and we stop the test at that time. In special conditions, When we are considering other etiologies, we might check insulin antibodies, anti-insulin receptor antibodies, IGF-1, and plasma cortisol. Limitations of the prolonged fasting test include that normal subjects can have low blood glucose, again, pregnant women as an instance. Also reported false negatives, so these patients will have suppressed insulin in some insulinomas. And also reported false positive, that is high insulin in the presence of insulin antibodies. Very important to keep that in mind. Now, in patients who have reactive hypoglycemia, the procedure of choice is the mixed meal testing over a few hours. And that test should last for 3 to 5 hours. It should be done after an overnight fast. And patients should have a meal that is similar to what provokes their symptoms. We should get a baseline. Then every 60 minutes labs for the panel I mentioned earlier. And whenever the patients have hypoglycemia, then we order the panel again and we check the insulin antibodies. Now, the three most important etiologies for hypoglycemia is exogenous insulin secretion. In this, we will have a high insulin, high C-peptide, and high proinsulin. Then we have the endogenous, low insulin, and then we have the endogenous insulin secretion, in which we have high insulin, high C-peptide, and high proinsulin. And lastly, we have the entity with the oral hypoglycemic agents used, in which we have high insulin, high C-peptide, high proinsulin, but of course in the presence of oral hypoglycemic agents. Imaging is indicated when we're suspecting insulinoma or other tumors or pancreatic hyperplasia. These might include MRI, somatostatin, PET, or GLP receptor scans. We might consider endoscopic or intraoperative ultrasound in many cases, as well as selective arterial calcium injections. Now, what's the management of hypoglycemia? Now, surgical treatment is curative for many patients, including insulinoma, pancreatic hyperplasia, and other tumors. On many occasions, we might consider reversal of bariatric bypass in patients who have resistant hypoglycemia. Dietary treatment is also indicated, especially for patients with reactive hypoglycemia, and these will include frequent feedings, restrictions of carbohydrate. Sometimes you might consider severe restriction down to 2% only, then avoidance of high glycemic index foods and simple sugars, and the addition of protein in every meal. In addition to diet, we might consider many medications. For example, for reactive hypoglycemia, we should consider acarbose and GLP agonists. For patients with autoimmune hypoglycemia, we might consider prednisone. And for fasting hypoglycemia, we might consider diazoxide, calcium channel blockers, and somatostatin analogs. All of these will suppress insulin secretion. Let me now move to a few clinical scenarios. I have 3 scenarios. I'll try to do all of them. This is a 66-year-old lady who had 3 episodes of loss of consciousness within the past month. Each episode actually was preceded with blurred vision, palpitation, and sweating. Her consciousness was fully recovered after she was given glucose in the mouth by her relatives, and she reported no relation of these symptoms to her meals. She has a history of hypertension and history of bariatric surgery 4 years ago. Her baseline BMI was 55. She has a family history of type 2 diabetes, 5 patients in the family. They're all on insulin. And she had, she mentioned that she was not taking any prescribed medications. Her physical examination was essentially normal, and her labs, basic labs, were also all normal. And A1C was also normal. She admitted for evaluation. However, she refused prolonged fasting test. But within 24 hours of her admission, a patient developed symptoms of hypoglycemia, and that was about 3 hours after her breakfast. Labs during that episode revealed a glucose of 2.7, insulin level elevated of 31, C-peptide was elevated at 1.74, and high cortisol, as you expect, and she had negative sulfonylureas. So again, patient had high insulin, high C-peptide, high proinsulin, and negative oral hypoglycemia, hypoglycemic agents, and that is consistent with the endogenous insulin secretion. So what would you think as a second step for this patient? Would you check her insulin antibodies? Would you refer for MRI or PET scan? Would you review her medications that she denied taking any medication, prescribed medications, and review her drug history? So simply, yes, always you have to review other drug history and other supplements that she might be receiving. And in fact, this patient, when we reviewed her history further, she was actually taking this supply of Mancudo, which is considered as antioxidant, but also is used in Southeast Asia as an anti-diabetic medication. So the diagnosis for this patient was mainly herb-induced hypoglycemia. However, probably her bariatric surgery history complicated her symptoms. Management was straightforward. You stop herbal medications, you start diet instructions, and we started acarbose for her. And within the next 48 hours of admission, patient had no recurrence of hypoglycemia. And now, 3 months after the fact, she had no hypoglycemia at all. Let me move to the second case. This is a 67-year-old lady. She has diet control type 2 diabetes, hypertension, hyperlipidemia, reflux. She had idiopathic hypercalciuria and kidney stones. Her medications include indapamide SR 1.5 milligram daily, losartan, atorvastatin, clopidogrel, and she was not on any oral hypoglycemic agents. 2 weeks before this presentation, patients started having episodes of hypoglycemia 2 to 4 hours after meals, blood glucose of less than 50, and she was referred, she was seen in the ER twice and confirmed hypoglycemia at that time in the emergency room. Her lab evaluation confirmed normal UEG, GFR normal, TFTs and LFTs are normal, and her A1C was 6.1. Using flash glucose monitor and also using the meter showed multiple episodes of hypoglycemia. We admitted her to the hospital, and during admission, she was kept fasting after her dinner for 60 hours, and she did not have any hypoglycemia at all. However, when fast was followed by a mixed meal of her choice, patient had a blood glucose of 306 1 hour after that meal, and that was followed by a blood glucose of 2.7 4 to 5 hours after that meal. Labs done during her symptomatic hypoglycemia showed blood glucose of 2.7. Insulin level was very high, 2,000. C-peptide was minimally high at 1.7. She had negative ketones. Additional testing confirmed that she was not taking any oral hypoglycemic agents. Now we repeated her labs on the next morning, and her blood glucose after breakfast was again elevated, impaired glucose tolerance, but her insulin was really very high at that time, almost 3,000. And again, her C-peptide was not that elevated, only triple the normal range. She had high proinsulin, and her, again, proinsulin was elevated. So she had the summary. She has hypoglycemia, very high insulin, and slightly elevated C-peptide. Now, if you look at this carefully, again, very high insulin level, C-peptide minimally elevated. And if you carefully follow this, you will find that only endogenous insulin and only insulin antibodies that cause this picture of all of these are elevated with no oral hypoglycemic agents. Now, very important point here, and that was the ratio of insulin to C-peptide. Normally, the C-peptide ratio, the insulin to C-peptide ratio is 1 to 5 or even 1 to 15. And that is due to the fast removal of insulin during the passage through the liver. The ratio is 1 or less actually in insulinoma. And however, the ratio usually is reversed and greater than 50 in the presence of insulin antibodies, because the presence of insulin antibodies will keep the insulin in the system, in the circulation for a long time, and it will not be cleared. So we checked the insulin antibodies for this patient, and they were actually very high. So the diagnosis for this patient was insulin autoimmune syndrome after exposure to clopidogrel. A review in history, her history showed that she started this 1 week back before this presentation. Mechanisms of insulin autoimmune syndrome in these patients actually is the sulfohydryl group that interacts with the insulin itself, and it makes it immunogenic. Usually during fasting, the insulin antibodies are available. They're not fully occupied. So when meal is given, then the insulin secretion will increase, and all the extra insulin will be bound to the insulin antibodies, causing postprandial hyperglycemia, because this insulin is ineffective at that time. However, later, whenever we have more insulin and all sites on the antibodies complexes are saturated, then we will have a sudden release of insulin and the development of severe hypoglycemia. Management of these patients will depend on discontinuation of the offending agent, a low carbohydrate diet, and medications that include acarbose to treat the reactive hypoglycemia, but also glucocorticoids. For our patients, you could see here we stopped the clopidogrel and we started prednisone treatment. Within 48 hours, patients did not have any more hypoglycemia. We, over the past few months, we tapered her steroids slowly. Over 7 months, insulin and C-peptide went down to normal slowly, and we had negative antibodies in October here. We started in March, and she had no recurrence of hypoglycemia at all. So the conclusion for this case is very important. Insulin antibodies should be actually considered in patients with high insulin and hypoglycemia, especially if the ratio is reversed. Very important to review the ratio of insulin to C-peptide, and very important because in this case you could prevent further evaluation, costly and probably unnecessary dangerous surgery. Let me now move to the third case, last case. This is a 76-year-old man, history of hypertension for 5 years on ACE inhibitor. He has a 3-month history of episodes of sweating, anxiety, and tremor, also visual complaints and dizziness. All disappear after drinking juice. Reviewing his medical records, actually, this patient had a car accident 4 months ago, and in that admission in the emergency room, his blood glucose was 2.4 millimole. His physical examination and labs are basically normal. After 12 hours of fasting, prolonged fasting, we attempted. He had a low blood glucose of 2.2. His insulin was 222. C-peptide was also elevated. Proinsulin was elevated. And he had negative ketones, high cortisol, and negative and negative sulfonylureas. He denied taking any herbs or, again, no oral hypoglycemic agents. And again, if you review this, this is actually, again, consistent with endogenous hypoglycemia. We referred this patient for an MRI, and the MRI confirmed a 1 centimeter mass in the tail of the pancreas. We did imaging study. We used the gallium dotatate PET scanning, and that also showed a 1 centimeter, same location, avid area with uptake. And also very nicely and very important, this PET scan showed a 6 centimeter lipoma that should not require any further evaluation. Patient was referred for surgery and had total pancreatectomy and splenectomy. And right after surgery, patient did not have any recurrent hypoglycemia. However, 6 months later, he developed type 2 diabetes. So my summary and conclusions, Mrs. Chairwoman and ladies and gentlemen, Whipple's trial should be satisfied to make a diagnosis of hypoglycemia. Loss of consciousness is highly suggestive of an etiology, a serious one. Elderly people have fewer symptoms of hypoglycemia when you compare to younger people. Careful history, physical examination, and basic lab evaluation can probably identify most common causes of hypoglycemia. Testing should be done at the time of spontaneous hypoglycemia, and if that is not possible, then we should attempt prolonged fasting or mixed meal test. And that is my last slide. These are my references. Thank you very much for listening. Thank you.
Thank you very much, Dr. Bashar, for your presentation. Please stay with us till the end of this session, and we will have the questions later on. So our next speaker is Professor Andrew Bolton. Professor Andrew Bolton is the Professor of Medicine, University of Manchester, and Consultant Physician in Manchester Hospital. Professor Bolton is a graduate of Newcastle upon Tyne and subsequently trained in Sheffield and Miami, and then he been appointed at Manchester University. He authored more than 550 peer-reviewed manuscripts and book chapters, mainly on diabetes, lower limb, and renal complications. Among his many awards, he was received the ADA Roger Leadership and the European Association of Study of Diabetes Camillo Prize, and was the first recipient of the International Award on Diabetic Food Research. He was the 2008 winner of the ADA Harold Rifkin Award for Distinguished International Service in Diabetes. He received in 2012 Georgetown Distinguished Achievement Award in Diabetes Limb Salvage. He is the founding chairman of the Diabetic Food Study Group and was previously the chairman of the Postgraduate Education and then the Honor Secretary Program Chair for the European Association of Study Diabetes. Until late 2015, he was the president of the ISAD. Currently, he is the president of International Diabetes Federation, IDF, and the chairman of the EURADIA, European Alliance for Diabetes Research. He's going to talk about the diabetic food, the modern treatment, and the use of a smart technology.
Thank you very much for your generous opening. It's a pleasure to be with you. I speak to you from the north of the UK, and it's actually a rather warm, sunny day, and most unusual for this time of the year. It's even 21 degrees today. Somewhat cooler than Dubai, but there we are. So, the Americans, the term PITS means it isn't too good. But I would put to you that diabetic foot care is the PITS, and it should be better. And the PITS can stand for prevention, identification, treatment, and service. So I'm going to go through some of these factors. We know who is at risk of foot ulceration from a number of prospective studies, many of them done by my group here and also in Miami. The most at-risk people for foot problems are those with diabetic sensory motor neuropathy and autonomic dysfunction, leading to dry skin, lack of sweating, and increased blood flow in the absence of peripheral vascular disease. The common, of course, if you've had a foot ulcer, you've got a very high risk of getting another one. Indeed, the risk is as high as 30 to 50% per year. Patients on dialysis are very much at risk, and with other microvascular complications. And obviously, if you've had a previous amputation, you're at risk of a foot problem on the remaining foot. Now, it was Dr. Paul Brand, working in India in leprosy, who said quite rightly that you do not need expensive equipment to diagnose the high-risk foot in diabetes. And as I mentioned in my talk yesterday on neuropathy, it is the words of Dominic Corrigan, famous Irish physician. Corrigan signed the collapsing pulse of aortic incompetence. He said that the trouble with most doctors is not that they do not know enough, but they don't see enough. They look, but they don't see. All you need to do is look at this foot to see its high risk. Prominent metatarsal heads, callus from the dry skin and high pressure, pes cavus, clawing of the toes, dystrophic nails, and some small muscle wasting. I rarely show complicated slides. This is the most complicated I will show this evening. Diabetes leads to somatic neuropathy with loss of pain and proprioception, but also motor dysfunction with small muscle wasting in the feet, and an imbalance between flexors and extensors. Somatic neuropathy, motor neuropathy I've mentioned, autonomic neuropathy, as I've already said in the picture, decreased sweating, altered blood flow, it's increased due to sympathetic dysfunction, sympathetic nerve dysfunction, leading to the distended the distended foot veins you see on the foot, the warm but insensitive foot with distended foot veins, the sign that we described back in 1983. The dry skin plus high pressures leads to the dry skin, the callus. The callus itself can cause ulcers. And the green circles demonstrate where patient intervention, self-foot care can help. Examining the feet daily, for example, down here on the bottom left. And up here, moisturizing the feet with moisturizers, regular foot care. You've got good podiatry in the Middle East and well-fitting shoes. The commonest cause of foot ulcers in my country is shoes that are inappropriate for the shape of the foot. In other countries, for example, in India, walking barefoot can be very important on the hot ground. And of course, if someone does develop a foot ulcer, it's always a good idea to wear the offloading device you're given. So one key question is this: does education alone reduce the incidence of first foot ulcers? For example, in those with high risk due to diabetic neuropathy. And sadly, I cannot prove that it does, even though inherently we all educate our patients in self-foot care. Here's a systematic review from Utrecht in the Netherlands from Dorstein and colleagues. And this concluded that there was insufficient robust evidence to support education alone to prove that this worked in reducing ulcers. Too few trials, poor study design, insufficient numbers, and duration of follow-up. But we should interpret this not as evidence of no effect, but lack of good evidence. Here's another study from the UK, this time a systematic review, again suggesting that there is insufficient robust evidence to support population-based foot screening. We should be screening our patients with diabetes every year, and those with high risk require podiatry and further education. So if you've had a foot ulcer, does education reduce the incidence of getting further ulcers? Sadly, there's no evidence that it does. Here's a study from some friends of mine from Nottingham in the UK, and the patients with newly healed neuropathic foot ulcers were randomized to two groups. One had intensified education, group discussion, hand-to-hand, face-to-face interviews, discussion, how they should look after their feet and so on. The others were randomized to usual care, a handout, look after your feet, if you see a problem, come to the clinic. Now, although those who had the intensified foot education, the intensified group, reported better foot self-care, there was sadly, no evidence that this led to ulcer or amputation reduction. Now, I would put it to you that these people, their physical dysfunction is too great for education alone to work. So we need education plus something else. Now, smart technology is helping us in two ways, in measuring pressures and loads under the feet and foot temperatures. Now, that foot pressures are important in the neuropathic foot were confirmed by numerous studies, many of which I did when I was in Sheffield and later here in Manchester. My colleague, Aris Bevis, a Greek fellow who's now professor of medicine at Harvard, and Murray, we've shown in numerous studies that high foot pressures lead to breakdown under the high pressure areas, the metatarsal heads, in insensitive feet. And we know that plantar callus, the hard skin, is associated with high pressures and cause ulcers, but removal of callus can reduce risk. Now, nothing is new in medicine, and here's the late Dr. Paul Brand, nearly 60 years ago, working in leprosy in India and later in the United States, with very primitive transducers measuring pressures under the neuropathic foot. And he said that pressure is the critical quantity that determines the harm done by the force. Now, today, of course, we've got sophisticated ways of assessing pressures and loads under the feet. And this is like the mountains, as you see, for example, if you fly from here over Germany down to Italy, you cross the Alps and you see these peaks. These are the peaks of high pressures, which we see in many patients with neuropathic feet. Here's a Charcot foot with high pressure under the cuneiform metatarsal area here. And you see the high pressures under the foot, and these are at risk of breakdown. So we did a study recently published in Lancet Digital Health 2 years ago that we assessed novel plantar pressure sensing smart insoles, intelligence, if you like, to reduce the foot ulcer incidence in high-risk patients with a history of ulcers. And this was done with my very good friend and research colleague, Professor Neil Reeves, from the Manchester Metropolitan University, which has a fantastic gait laboratory. Now, we know, as I've already told you, that diabetic foot ulcer risk is high foot pressures plus loss of sensation. And pressure is a laboratory measure, but the concept that we can use pressures measured in the shoe to feed back to the patient started about nearly 20 years ago. And some big studies were done in Switzerland and other places. So what we aim to do is to investigate the efficacy of pressure sensing smart insoles for reducing diabetic foot ulcer recurrence. And this is the insole that we used that had in here a number of pressure sensing devices that could feed back wirelessly to a wristwatch that didn't actually tell you the time, but it gave you a pressure contour of the foot. It would demonstrate high foot pressures in red, and the wristwatch would vibrate if the patient, when walking, was putting very high pressure under a particular area. And the endpoint, of course, was a plantar ulcer, and those who had the feedback and those randomized to an active insole were advised to alter their gait or to rest. And they could follow that by looking at the wristwatch to see if that color the red color actually went away. So this simple device led to a foot ulcer reduction in the active group, in the who had been randomized to the insoles that fed back to their wristwatches. This was a randomized study. It led to a big ulcer recurrence that was significant, and even higher in those who actually were very compliant in wearing the insoles and the special shoes all the time. Overall, the study ulcer rate was low, as one sees when you do a study, because patients that tend to be more adherent. But the mechanism is pressure offloading, and this is patient empowerment. So here we have pressure that can be used as feedback to the patient during their normal day-to-day activities and walking. So the other thing we can measure is temperature. And again, I go back to Paul Brand, working at this time in India, in Vellore, the Christian Medical Center, in Karigiri in Tamil Nadu, and later in Carville, the United States Leprosy Research Center in Louisiana. And he said that infrared thermography, in other words, assessing temperatures under the foot, contributes to the care of the insensate limb. It can detect through heat areas of irritated skin prior to breakdown. And therefore, if you spot a high temperature, you might be able to stop the injury before it occurs. And this was from his paper. Here's a thermogram, and this patient could well have been lying on a surgical ward The patient had neuropathy and the feet weren't being turned, and you see a hot area over the heel, and there's no doubt that this is at risk of breakdown. But what his study showed was the foot warms up before it ulcerates. So one can ask the question, if nerve damage and mechanical stress leads to inflammation, and this leads to breakdown and faulty healing ulcers and could go worse, can we do something to stop at this stage by identifying the foot likely to break down before it actually does, by looking at the temperatures? And here are 3 studies, but just look at the middle one by my friend in Dallas in Texas, Larry Lavery. And this was a study done in patients with a history of foot ulcers, mainly Hispanic patients from South Texas. They were at high risk of developing recurrent ulcers. They had neuropathy with a previous plantar ulcer. And they were randomized to one of 3 groups. The structured group, let's start with the standard group here. These patients had pretty good care. They saw a podiatrist every 2 months. They were given good shoes, and they were given advice on checking their feet every day, and if they see something, to report to their podiatrist. And they were told what to look for. The structured group had all that, but they were also given a mirror. And being in Texas, patients were rather large, and many people couldn't examine their feet. So the mirror was on a long stick, so they could actually examine under their feet each day. And they were told if they see anything suspicious to report to their podiatrist. The third group was given all this, but they were also given a self-temperature monitoring thermometer. And they measured their foot temperatures comparatively between the 2 feet. And if they were more than 3 degrees Fahrenheit, or I think it was 3 to 4 degrees Fahrenheit warmer than the other, they were asked to rest and go and see their podiatrist. Well, the results were pretty startling. The standard group and the group with the mirror, they had 1 in 3, just under 1 in 3 patients ulcerated in that period of follow-up of 15 months. But the ulcer rate was significantly reduced, as you see here. In the enhanced group with self-temperature monitoring, the recurrence rate was less than 10%, compared with about 1 in 3 in the other 2 groups. So education plus an intervention such as self-temperature monitoring can be efficacious in reducing recurrent ulcers. Nowadays, we have smart mat technology. And here's a study by my good friend Rob Freiberg from Phoenix, Arizona. And in this study, they used a smart bath mat. It's like a pair of scales, but this fed wirelessly by Bluetooth to a central monitoring area. So when the patient stood on this, they could measure the temperatures and see if there was any difference. Now, this was just an observational study in 132 patients with a past history of ulcers. There was no intervention because they had to prove that it worked. We had daily foot temperatures were assessed remotely, and plantar temperature asymmetries were analyzed. Over 1 in 4, 29%, had foot ulcer episodes, and one could have predicted the development of these ulcers by a 2.2 degrees or more asymmetry between the foot that ulcerated and the contralateral foot, suggesting that prediction and prevention can be possible. And there are now randomized studies ongoing. So times are changing, as they say in America. What the traditional method is, seeing a patient in the clinic, prescribing drugs, orthotics, whatever, education, assessment of the feet, giving shoes, and so on. But now we've got the spectrum of remote management, where wireless device, we can have remote monitoring of blood pressure, glucose, lipids, remote consultations, which of course have accelerated during the pandemic, remote foot pressure monitoring for pressure, temperature, and pre-ulcerative lesions, as you see here. Remote fitting of shoes with offloading and feedback, if the offloading is good, and so on. So the solution may be continuous foot monitoring systems to prevent diabetic foot ulcers, a real-time sensor-enabled wireless device for the diabetic foot. So the smart technologies are thermography, such as this, foot temperature, a smart thermography mat, measuring patients' temperatures, and now if the podiatrist or whoever sees asymmetry, you can call the patient and say, look, this foot's at risk of ulceration, you need to rest, stop walking, and so on. And these temperatures studies are ongoing, and we also have continuous plantar pressure monitoring. So see it, save it. The patient can now see their feet through a smart device, through an app, and look at the pressures and loads under the feet, or they can have this pressure stat, which we've shown to be very effective in assessing high pressures. You can give that to the patient. The darker areas are dangerous. Dark is dangerous. That's the area to check under your foot. Seeing is believing. Here's one of the devices that can be used at home, like a bath mat, but this feeds back to the patient. They can see their foot, this hot area here, and this can be transmitted to the patient's cell phone. That this is helpful. This is American humor. I apologize for it, but success is, they're saying, a success because these people have developed smart socks, and they won the Consumer Electronics Show prize of $50,000 for the best invention. And they have smart socks that the patient can wear and can feed back and tell them the temperature, and can look at a temperature differential and identify a preulcerative lesion. So there's a lot of work going on in this area. But I'll leave you with a few quotes of Edward Wilson, who said, "You teach me and I forget, you show me and I remember, but you involve me and I understand." So now patients can be involved in their own foot care using smart technology. Lastly, I'm going to spend a few words about new treatments. I'm running out of time because I've got another engagement in 5 minutes, but let's talk about treatment. We know that a diabetic foot ulcer should heal if there's good arterial inflow, if infection is aggressively managed and pressure is removed from the margin. We're least good at this. But there's been a renaissance in diabetic foot care with new treatments from studies, from articles, reviews saying this is how we should be doing trials, proper randomized controlled trials. Let's have an evidence-based approach. We have the Luca patch system, which has recently been reported, and this is bedside centrifugation without any additional reagents to generate a disc of the patient's autologous leukocytes, platelets, and fibrin. And then you put this plug into the ulcer. And this trial showed faster healing in difficult to heal ulcers. Then we have this other sucrose octasulfate dressing. This is a dressing that's been shown in a randomized controlled trial to be beneficial for neuroischemic ulcers. So we are now having evidence-based medicine to help in our management of diabetic foot. Hyperbaric oxygen has not been shown to be useful. It's rarely used apart from in the United States, and most randomized controlled trials have not supported its use. But now we're having evidence for topical oxygen. They're not all the same, but they're all showing improved results. And here's a result just published, again by Freiberg and colleagues, cyclical topical wound oxygen, TWO2 for chronic diabetic foot ulcers, a randomized controlled trial that shows that those who were randomized to topical oxygen, wound oxygen therapy, had superior and faster healing. So there are new treatments on the horizon. Lastly, infection. We still use clinical definition. Here's a Charcot foot. I think there's no doubt in anybody's mind or eyes that this is infected and abscess under a Charcot cuneiform metatarsal joint here. We use the usual signs of infection. And remember that antibiotics are overused. They're not wound healers, growth promoters, household cleaners, scalpels. If there's pus, let it out and treat when there's clinical sign of infection. Here's a randomized controlled trial from Spain that showed those with local osteomyelitis do just as good on antibiotics than with local surgery. And here's a very important trial published a couple of years ago showing that intravenous antibiotics are not superior to oral antibiotics in osteomyelitis. And these are going to challenge the current standard of care, these trials. So, although the incidence of foot ulcers continue to increase, major advances have occurred. We can aggressively treat infection. We've got now new technology for a revolution in home-based diabetic foot care, and we've got therapies that have been proven in randomized controlled trials. So remember from the Bible here, before you speak, learn, but before you fall ill, take care of your health. So we can prevent foot ulcers. We can engage the patient much more. And lastly, as last night, I'll remind you of the International Diabetes Federation virtual Congress, which is occurring this December on diabetic complications, COVID-19 and diabetes, but also the launch of this year's IDF Diabetes Atlas that tells us the up-to-date prevalence and incidence of diabetes across the world. And we have a symposium to celebrate 100 years, in fact, this month, since the first animal was injected with insulin in Toronto in 1921. So thank you very much for your attention. Shukran.
Thank you very much for a very interesting and topic, and with the updated technology for diabetic food. So I don't have questions so far. So
I must have given all the answers then.
Yeah, mostly it's been answered. So I don't have really. I don't have questions right now. So thank you very much. Dr. Bashar, I think I have a question. Did you answer the question that we have it here?
There was one I answered. There is another one. I don't know the answer.
No, the first one, it's not for you. I think for the satellite meeting. But there was a question before, maybe in the chat, that is the reactive hypoglycemia. Is it by exclusion, or do we have to do something with this? I think I read it in the chat earlier.
Yeah, I mean, reactive hypoglycemia is low blood glucose after meals. So, I mean, usually we depend on history, full history. Then we might use the mixed meal for that. I know it's very hard then to figure out what's the cause of reactive hypoglycemia. So, again, history is the most important thing there. Causes of reactive hypoglycemia, very complicated.
So, I think there is no more questions. So we will conclude our session today. It was a pleasure to have you here. Thank you very much. And hope to see you in other meetings. Okay.
Thank you, Dr. Assalamu alaikum.
السلام ورحمة الله وبركاته. الله معك. مع السلامة.